Good morning, everyone. Welcome, and thank you for joining us this morning for our third virtual donor briefing. Over 100 people signed up for today's briefing, and so I'd like to welcome all of you. And before we start the program, I wanted to share some good news. Thank you, Carmen. It's been a wonderful week for the foundation, for our nonprofit community, and for our donor community. I know many of you were involved earlier this week in the Great Give as donors, board members, and nonprofit staff. In case you didn't hear the final tally, we have it on your screen today. We raised more than $3.5 million to support our community's nonprofits. And this is almost twice as much as last year's Great Give. And we're thrilled with this year's results. In addition, more than $2.7 million has been raised for our COVID Community Fund. As the saying goes, it truly takes a village, and we are deeply grateful to each of you for being part of our village. I thank you so much on behalf of the foundation for the many ways each of you make our community a kinder and better place. Okay, before I turn the program over to Christina and our amazing presenter Marcella this morning, Carmen, if you can go back to the housekeeping slide. I just want to, many of you are getting used to Zoom like we are getting used to Zoom. All participants are muted. If you have any difficulties, please contact us on my screen. It's in the bottom in the chat box, and write your question there, and we have staff ready to help you. And we will have time for questions and answers. And please put your questions in the Q&A box, and we will try to get to as many as we can. If we run out of time, because I know Marcella has a lot of good information, we will email you and respond to you sometime today or Monday. Okay, again, thank you. And I now turn the program over to my colleague, Christina.
Good morning, everyone. Thank you for joining us. Carmen, can you move the slides forward one? Thank you. So I'm just going to give you a quick update on some of the themes we're seeing about the needs in Greater New Haven from what we're hearing from nonprofits. And I'm also going to tell you a little bit about the grant making from our COVID fund before we turn it over to Marcella. So we are seeing through the grant making and what we're learning and hearing from nonprofits, we are seeing some themes emerge, which I don't think will be surprising. We are seeing a significant increase in demand, particularly around basic needs, and especially around food insecurity. And a lot of this increase in demand is the result of people who have not in the past had to pursue services who are now trying to access some of these basic needs services. There is also, as Marcella will talk about in great length, emerging racial and ethnic disparities, quite troubling disparities in hospitalizations and deaths, in addition to the fact that this crisis is just shining a light and exacerbating the already existing racial and ethnic disparities. We're seeing organizations that have overwhelming revenue losses from closures. They've had to cancel events. They've had to transition their services to remote or telemedicine services. Overall, they're facing challenges in delivering essential services. There are significant challenges in education and getting children access to what they need for distance learning. Many organizations are or are contemplating laying off staff. And I do want to take a moment to say that we are just, it's amazing to see how these nonprofits and how this sector has rallied to continue to support organizations, but to continue to support individuals and vulnerable populations during this difficult time. It really is, it's amazing. So I'm going to tell you a little bit about the grant making from our COVID Relief Fund. As Dottie had said, we're doing this work in partnership with the United Way of Greater New Haven. And thanks to many of you, we've raised a significant amount of resources that are already being distributed to the community. The committee is made up of 6 individuals appointed by the foundation and United Way. Most of the individuals are existing or former board members of the 2 organizations, and you can see who those individuals are on our website. We have awarded nearly $1.3 million in grant making so far to many organizations. You can see the full list on our website if you go to our website. And the purpose of the relief funds, excuse me, has been to support organizations working on the front lines with individuals who are most severely and disproportionately impacted by the COVID crisis. We have, in the first 2 rounds of grant making, we have leveraged our own knowledge, our collective knowledge with United Way and our networks, and have awarded those grants on a proactive basis based on organizations that we know well and organizations that we know have important relationships with the community. We are transitioning that process right now into a more responsive process. We are going to be posting an application on our website next week to apply for a grant, and you can look out and look for that information. We are really trying to focus our grants, the second round of grants and the future grants, on really addressing these racial and ethnic disparities that we see emerging. I am happy during the Q&A to answer any questions about our grant making or the fund or our work with United Way. But I do want to transition to the main event, which is Dr. Marcella Nunez-Smith. I will say that, Marcella, we are grateful that you've made time for us this morning. Marcella is one of the individuals working on the front line of this crisis. She is a physician and seeing patients. She is a researcher. Most of her research work is focused around equity. She is working on the advisory group to reopen Connecticut. She's on the foundation's board, and she has been on our committee for the COVID Relief Fund, our grant making committee. I don't know how she makes time to do it all, but she does. So thank you, Marcella. She's going to do about a 20-minute presentation, and then we're going to shift to Q&A. Thank you.
Great. Good morning, everyone. And thank you so much, Christina, for that introduction and for the invitation today. And of course, you know, I cannot start without saying thank you to the foundation and all the amazing staff leadership now, really more than ever. So my hope today, I will share my slides in a moment, is to start a conversation. We will talk about racial and ethnic disparities, and it's not an easy topic, but I hope to explore some opportunities for things that we can do to innovate and to lead on best practice to address these disparities. So I thank you all very much for coming and look forward to the question and answer period. All right, hopefully everyone can see the slide deck. So very briefly, in the sort of 20 or so minutes that I'll be sharing slides, you know, I hope to walk us through these different components. My overall goal is to provide some context, both locally and nationally, on inequities, and to begin to explore some paths forward. So we'll look at some of the national and local level data that we have, and then we'll turn to thinking about some of the multifactorial contributions to the COVID disparities that we're witnessing. And then specifically looking in New Haven, and probably spending the most time looking forward and thinking about some of these emerging best practices, where there are opportunities for us to learn from other places and other locales, and where we in New Haven and in Connecticut are in a position to really be the thought and action leaders. I think all of you probably are as alarmed as I am and have been as the data began to emerge across the country. The extent of the differences and unequal exposures, incidents, hospitalizations, and death by race, ethnicity. What's on the screen now is just sampling, really. It shows that the disparity knows no geographic limitation. So whether we're in Louisiana or in Chicago or here in New England, the same pattern repeats. Black and brown communities have been disproportionately hit, devastatingly so, by the novel coronavirus and its sequelae COVID-19. In Connecticut, we similarly see that the impact and influence and effect on our citizens has not been uniform. It's a simplified graph. I will sort of add here, as you look at these cases per 100,000, on the x-axis, you'll see by race and ethnicity. And this is cases, so confirmed cases as well as deaths. That some of the work that I'm doing with my colleagues when we look at age adjustment, so these data are not age adjusted, but if you look at age adjustment, the disparities are even perhaps more striking and more surprising as we see that the people who are most affected in our racial ethnic minority groups are much, much younger and have sort of more severe outcomes than would be expected of their age-adjusted white non-Hispanic peers. I want to turn to look at some of the disparities data here in Connecticut and in New Haven. On the left, and these data are a few weeks old, but the pattern more or less remains in terms of the hospitalizations that we see disproportionate to the population representation for African Americans in New Haven, approximates for Hispanics. I will say it's not on the slide, but kind of knowing from the frontline work in Yale New Haven system, the patients who need escalation in care, particularly to our intensive care unit, are really disproportionately our patients of color and really disproportionately Hispanic patients. And so as we sort of walk through this and think about questions we need to answer, that certainly looms large. One of the ways to look at data, one of the themes for today is going to be data. We need to be data driven. We have to collect high quality, good data. We're very fortunate in Connecticut to have an infrastructure, I think, that can really support us and help us in this. This is a different way to look at the numbers across our city of New Haven. And on the left of your screen is the COVID-related hospitalizations and a heat map by race ethnicity. And on the right, COVID-related deaths, also the same. The takeaway from this slide is when you look at the most granular level, we do see disparities that are worse in particular neighborhoods. And so getting as hyperlocal as we can with the data so that we can appropriately target resources is really an imperative. But just this recognition that not all communities, not all neighborhoods, not all households are affected the same way is a really important awareness for us to start the conversation from. I really want to pause as we talk about Mr. Johnson. You know, as Christina said, I spend a lot of my time thinking about data and big data and population level data. And I think that that's important, but nothing really substitutes for understanding why we're motivated to action. I want us to all take a moment to honor the life of Mr. Robert Johnson, who is no longer with us. Mr. Johnson was a patient with many multiple existing conditions. He was dependent on dialysis. He used a wheelchair for mobility. he became symptomatic and was unable to achieve and obtain a COVID-19 test or any therapies before he died at home. He did present to healthcare, and this was a moment where we failed. And we failed Mr. Johnson and his family. And there are many lessons to be learned from this tragic incident. And sadly, this isn't the only personal tragedy that's occurred since the beginning of the COVID-19 pandemic. So why do we see these disparities? There really are several things that we have to take into consideration. Perhaps if there's one message to walk away from today's discussion with, it's for us to know that the disparities we see now are really the result of what have been long-lasting, intergenerational, structural, and systematic disinvestment in communities, and many communities of color. This isn't unique, of course, to Connecticut, but it is a reality of the history of our country. As we discuss racial and ethnic disparities, I think it's important to keep in mind that race is not a biological determinant. And so we must think about the social conditions that drive these outcomes. On the screen now, this is not an exhaustive list, but certainly things we have to consider and address, such as institutional messaging and what we know can be often misinformation that's spread or distrust in messages that are communicated. It can be really quite difficult to work from home for those who have low-wage essential jobs. Social distancing is in fact a privilege that is not available to everyone. People on the call will likely know that there's limited access to high quality healthcare for many communities across our country. People who live in urban settings are often more likely to live in densely populated neighborhoods as well as homes. And as referenced already, there's a greater burden of coexisting conditions that can increase the risk of severity. And the role of these social risk disparities cannot be overstated. And so even before COVID-19, we were aware of great gaps in terms of income inequality across New Haven, very high rates of food insecurity that were also patterned along with race ethnicity, and high rates of housing instability across children and adults. So I wanted to just list, and again, not intended to be exhaustive, but to get us thinking about some of the really urgent issues in public health and healthcare, and where there really is a role for all of us to think together about strategies and solutions. So you've already heard about the explosion in the need for sort of basic supports, in particular food, and that we anticipate may grow given all of the economic realities and challenges that have accompanied the pandemic. Something we've been thinking about a great deal on the State Reopen Advisory Committee is, as we roll out plans for testing and contact tracing, how will we provide and help support both safe and effective isolation and quarantining of COVID-19 patients who may need it? So if you're unable to have your own bathroom, for instance, which is the advice, how can we be helpful? How can we help provide food to those who might need it, economic support to those who might need it in order to self-isolate? How do we ramp up access to timely testing? And certainly for active infection, as well as for antibodies. And we can talk more about that, but definitely a need to innovate in that space. Even just thinking about the first round of testing in our state was really available through drive up only. And for many residents in New Haven and Connecticut, that was automatically then out of reach if you didn't have a vehicle. I think really important, we're on the verge of thinking now about contact tracing and what that will mean. So once you identify a person who has COVID-19, it is the public health practice to then determine who might have been exposed through that person and to recommend quarantining to them. But for many communities, people who are undocumented and others, what does contact tracing exactly mean, and how might we think about that in a way that is inclusive and community engaged? The protection of low-wage essential workers has been leading in the news, most certainly. And then our need for data that is timely, coordinated, accurate, and of high quality. Within the healthcare space, we similarly face particular challenges now. We're trying rapidly to transform care, this migration to telehealth platforms, but kind of who is able to access that? A lot of the payment requires video components, and so thinking about policy revisions so that practices aren't disincentivized from reaching out to patients who might only be able to talk by phone, but yet we know many of our patients don't even have a reliable phone number. For many of my colleagues, there's been a great challenge and questions as to how to best connect patients with these community resources referenced above, such as basic needs. You may have heard that within the clinical care space, we are practicing under crisis standards of care. And that's led to many conversations about things like care rationing and the reality of social isolation for our patients as we enact very restricted and limited visitation policies. It might seem ironic, but the healthcare sector is losing revenue at this time where we've ramped services up so highly. And so as we think about where there might be sort of revenue centers in elective procedures and other things that have been suspended, many healthcare organizations are now furloughing employees and laying off staff just as we need them the most. We've also had to deal with reconfigurations in our workforce if people have been deployed to the front lines. We try to deal with, particularly in the outpatient management of COVID, with the reality that many people do not have a medical home and now desperately need medical help and guidance. And we're keeping an eye on whether there are disparities in access to experimental therapies, such as convalescent plasma, or now with some of the newer therapeutics. So I'm going to pivot now to think about looking forward and where there might be some emerging best practice and opportunities, I think, to lead. And so looking around the country, we see maybe some examples that might guide us. So how do we think about identifying where our most at-risk communities are? Oakland is sort of using one approach, kind of taking a specific look at their data, applying what they refer to as a vulnerability index to, at the most granular level, help target resources. And that is certainly something we're able to do here. You know, as we walk through, I'm going to lift up just some of our really rich assets that we have. And certainly Data Haven is one. And from the beginning, Data Haven has been tabulating and disseminating critical COVID-19 information. And I think we'll be at the center for us trying to think about how to target limited resources where most needed. And as I referenced before, you know, thinking about kind of supporting our most at-risk populations, we do know that many people will be advised to quarantine and isolate, yet many others will be advised to stay home and stay safe through the initial phases of the reopening. As we look to other state plans, we're seeing that many miss a focus on the most at-risk populations. And so whether we're thinking about particular subsets of people over 65, those who are living in nursing homes or other congregate settings or who rely on in-home support, people who are living with coexisting high-risk medical conditions or immunocompromised, those who have low income or are unable to effectively self-isolate at home, our frontline workers, our caregivers, people who are undocumented, those living with housing insecurity, and those who are incarcerated. Certainly, there are population-specific considerations for each of those groups. And we recognize that reopening may put at risk these populations in specific. So one of the things we propose, I won't walk through this for time, and this isn't for sort of sharing beyond our conversation today, but I would just draw your eye to the to sort of the bottom end of the screen. You know, as we ramp up our tracing and our testing, I think it's really important, and we're working hard at this at the state level, to be coordinated in how we sort of outreach to patients, to cases and exposures, how we make available resources that might be needed, such as food or even temporary housing, to help people adhere to recommendations. It's also important that we make sure people are safe and that we're monitoring and providing clinical checks for those patients who are at home and don't have a medical home that can provide that type of advisement and guidance to them. Together we've thought, and this, we've tried to take a very holistic approach to thinking about what domains of support might be needed moving into some of these reopening phases. And again, this is where I think that in Connecticut, as we are very intentional and think more deeply about at-risk populations, we might be able to guide national conversation and practice. So how do we provide some of those basic needs aforementioned, like food access? But we also have to think about technology and connectivity. We have to make sure that healthcare services aren't uninterrupted. So if someone, for instance, is on medication-assisted therapy, such as methadone for opioid use disorder, we have to be sure that they can get that while in quarantine or isolation, or dialysis, or other mental or behavioral health supports. Temporary housing. How do we help people maintain dignity sort of through personal care support, even issues of personal hygiene while in quarantine or isolation? And certainly the thoughts around economic relief and providing job and salary protection. Here is where I just want to sort of double and triple down on what I see as a very rich nonprofit and philanthropic landscape across New Haven and Connecticut. And this is certainly not exhaustive, but where we have to work together in very strong public, private, nonprofit, and philanthropic sectors to think about how to respond to all of those domains of need and support moving forward. So the issue of communication, and I think I would just stress here that we can think about global examples, but we want to promote a culture where real-time data are available and that anyone who wants to access it can, and that the visualization component can make it sort of very simple to understand. This is one example. That was one example from Singapore. Canada has really good examples of how to simplify messages that we then can distribute quite widely and that can be very accessible regardless of literacy. So I think having data, having very smart and targeted educational campaigns are critical. But where I think we might innovate and where there might be opportunities for us to move the conversation forward is around the messenger. And so important to think about the message, but also who delivers it. Community health workers have been invaluable for decades in our healthcare work, thinking about how to identify people who are of, from, and in communities most affected, to provide them with training and an employment pathway, to intervene critically at times of great need, to provide sort of accurate and trusted messaging. And so I see now, this is, on the left is one piece from the Journal of Health Affairs, but I see now as the time for us to mobilize around community health workers now in our response, in our reopening, and certainly in recovery. So, I've sort of referenced many, many times kind of data and how we can look at data. This is yet another snapshot of thinking about county and looking at the county level. This is from the Commonwealth Fund. And if you look at sort of counties that have higher or lower proportions of Black residents, you can see the top line are those counties with higher numbers of Black residents versus gray. So sort of reminding us again that the phenomena we see are not entirely going to be at the individual level, and neither can our interventions. So even as we talk about data, I just wanted to share with you that, across the country, we still are very silent on the data around race and ethnicity and disparities. Everything that you see gray here, their data are not available, or were not as of a few weeks ago. And so even as we think locally for solution, we do have to look nationally for a push to release race ethnicity data. Everyone has heard that what we need is increased testing and certainly increased tracing. We'll have to be creative as we do that. This is one example from LA, but we have already heard about the potential need for mobile testing, being able to do testing in communities where people live, rather than having people need to seek testing through many of the drive-ups or other walk-up. I wanted to take a moment and just kind of acknowledge some of the testing and testing realities for some of the most at-risk populations. So Fairhaven Community Health Center and Cornell Scott Hill Center both offered walk-up testing in response to the reality that many of the patients who might most need testing were unable to access it, as it was limited to drive-up testing only. And we know, for instance, in hard to sort of access test place, such as congregate settings, there is great risk for outbreak. In Connecticut, about 60% of our COVID-related deaths statewide are of nursing home residents. And many nursing home employees are also affected, themselves becoming sick and bringing the coronavirus infection to their home and losing loved ones. And so, as we look around and identify many, many heroes, I say this example of a partnership between Fairhaven Community Health Center and the Mary Wade Nursing Home to just this week test all residents and employees is a real inspiration and motivation to us all. And I want to end by lifting up this idea for consideration. And that's the creation of a COVID-19 Equity Task Force. To my knowledge, Chicago was the first location with Mayor Lightfoot, who in response to their staggering racial ethnic disparity data, called for a health equity task force to be stood up immediately that would develop hyperlocal data-informed strategies to slow the spread of COVID, as well as to improve outcomes among the most vulnerable populations. And many other municipalities and states have followed. On the screen is also Detroit's Corona Task Force on Racial Disparities. Louisiana as well has stood up a statewide health equity task force. They have already deployed resources. They're starting with $500,000 in funding to assess the state's COVID response, to provide health awareness educational media campaigns, and to develop health promoting interventions. Similarly, in Cleveland, there's a strike force to really make sure the messaging is appropriate and tailored, and to increase testing in Black and Brown communities. The Brookings Institute, as well as the National Governors Association and others, have now released statements encouraging every state to have an equity task force. There are voices already locally calling for this. One voice in that space is Health Equity Solutions, that's calling for a state equity task force as the state reopens. And as you can see on the right-hand side of the screen, some of the scope for the task force recommendations. But certainly for us here, we know that we can look to many other states now and cities for examples. So as we sort of wrap up, I just want to turn back to this list. It can seem long and daunting. Each one has many considerations, but I do think we're already moving in the right direction in public health and healthcare, with support from many, many people who are on today's call. And I do think that these are surmountable. So in conclusion, COVID-19 has revealed long-standing and pervasive racial, ethnic, and socioeconomic disparities. That is sure. There are certainly many urgent challenges that need to be addressed. But there are also many opportunities, and there are opportunities for us to adopt and adapt from others nationally and globally. And here in Connecticut, there are several opportunities for us to innovate on best practice. As we think about this next generation of best practices, though, I think we have to be sure that, as my colleague Ann Baker Pepe said in a meeting yesterday, we must be sure we do not rebuild another broken system. And I know together we can realize that. So the day will come when life will go back to something that we recognize as normal. And I'm grateful to be on that journey with all of you. I thank you so much for your time.
Thank you, Marcella. You gave us a lot to think about. There's a couple of questions that have come in, and I have a couple of questions myself. There are questions. You used Mr. Johnson as an example, and some people have asked around more specificity around that example, which I'm not sure if you're comfortable sharing. But people are asking, how specifically was he failed? Could you say more about that? What were the obstacles that prevented him from accessing testing? Because it appears that he would be considered part of the high-risk group or the vulnerable population.
Yes, no, thank you. And thank you for the question, and my condolences to the Johnson family. So this, I think, the answer often lies in our system failures. And so to the extent, of course, thank you for Christina to be able to discuss the specifics of a patient case. But I think if we already know that, particularly at the time Mr. Johnson was seeking testing, we have big problems in terms of our sort of pipeline of testing supply, and where testing occurs. So the ability to know where there are sort of outpatient testing centers, I think we are getting better at, but then we, didn't necessarily have disseminated that information widely. Knowing all the steps needed, right? Kind of having drive-up testing being the only option for a while. So the needs for Mr. Johnson to have been just more supported and coordinated in that process. I know this is something that we're certainly thinking about at Yale, and have begun to sort of identify many solutions for how to connect patients more effectively with testing, and follow up as needed. So systems improvement, I think, is the takeaway message. How do we make sure that the system isn't set up so that the default is that a patient might fall through?
Thank you. I'll go through some additional questions. There's some questions related to the data, so I'll try to lump those together. One of the questions is, why as a country are we being quiet about the racial and ethnic health disparities? I think some people, as I was, were surprised to see that map that you showed about where we're not getting data. Because I feel like we talk about this data a lot, at least here in this part of the country. And also, I'm wondering, is it the data is not being released, or is the data actually not being collected?
Great. So thank you for that. And the answer is both, and it depends on the locality. So, how do we get to good kind of quality data? So, one is we call for it, as many groups are. There are national alliances sort of calling for and demanding data. CDC is also calling for these data to be released. This is very tricky, right? I mean, from the beginning, the question is who gets to decide, right? So how do we even know? This has long plagued us in healthcare, and if who is assigning race ethnicity data in the first place? Much of those data are unknown. So literally, if you look at the data itself, it will say sort of on the death certificate, unknown. And so that's a big problem. Another thing that we have, so even at that first stage of, are people able to collect high quality race, ethnicity data, other kinds of data too, such as language. We as healthcare systems are starting to try to do a better job at that, but that's not universal. And so sometimes those data aren't even there to be obtained. And then certainly we now see many readjustments in terms of numbers as we retrospectively identify patients whose contributing or cause of death may have been COVID-19. So even, I think for some municipalities and states who may want to put out data, there are data challenges. And then there are others who, quite frankly, might be politically motivated to not, and to not share those data. But I think it is important for people to see that the number of states and cities that are compiling and sharing the data are few. It's the minority of places.
And what about, we talk a lot about racial and ethnic disparity data. Is there data along gender lines available around the COVID-19 crisis?
Yeah, so I know there are many calls for that too. We know from in other parts of the world that men are disproportionately impacted negatively. I'm not as aware of a repository of those data nationally. Many people are calling for that. And so I hope we do see that. But as of today, I don't think I think we're a step behind even on the biological sex data.
So we have close to 100 people on the webinar, and there's lots of questions coming in. So I'll just ask that you all be patient with me as I try to get through some of these questions. And I also know Will Ginsburg, our CEO, would like to make some remarks and comments as we go through some of this. So the next question is, has a COVID equity task force started in the greater New Haven area? And how could people share input and follow this group to help ensure that we do not recreate a broken system?
Great. So, I think it's something we should look at. I'm not aware, like whether or not any municipality is currently in the planning stages of this, or the state. I raise it. Everything is fast moving. So, I think Mayor Lightfoot in Chicago, maybe it's 3 weeks ago, that she sort of announced, I think, on national news that she was going to call together this task force. So I recognize that, it takes time for innovations to disseminate, certainly. I do hope it's something that we consider. And it's at least the early signs is that structure is very valuable in terms of coalescing, organizing, preventing duplication, but also kind of a group that's able to maintain one focus. Many other groups, of course, are thinking about lots of different things. And so if they can be singularly focused. I think I would also lift up Louisiana. So that's one state that kind of had staggering disparities. 70%, I think, of their COVID-19 deaths were people of color. And they, responded quickly with resource investment too. What is important to know, and can take it offline, is, a lot of the idea behind these task forces, is again back to the nonprofit sector, and that's often where it can be housed, or it can be housed in the government. But it really lifts up partnerships between all of those sectors. So I do hope that in Connecticut at the state level and maybe local municipalities would consider that as one approach.
Christina,
Yes, Will?
yeah, this is Will Ginsburg. Hello, everybody. And just a quick comment on this is one of the things I actually wanted to comment or ask, and maybe you just answered it, Marcella. First of all, thank you, Marcella, for this presentation, which is so illuminating. And actually, really, when you step back from it, just even a half step, you see that you really outlined a philanthropic, you've outlined the philanthropic response to where we are today and the next stage of how we're going to deal with COVID-19, with talking about the critical pieces: food, technological connectivity, healthcare, temporary housing, holistic well-being, and economic relief. I mean, I wrote those down like that's our charge. So I can't tell you how valuable this was and how much I appreciate not only this presentation, but what you're doing as a clinician and as a board member of the Community Foundation and as a member of our COVID-19 committee. I'm absolutely in awe of all you're doing. I don't know how you find the time or the energy or the fortitude to do what you're doing every day, but I can't tell you how much I appreciate it. My comment or question was actually what you were addressing just a second ago, which was, this idea of a COVID-19 equity task force. First of all, I would say I've heard nothing about that in my travels locally or in the state, but it does seem to me that's something that philanthropy can take the lead in structuring in a way, because the resources are there both at the local level and at the state level, and I'm actively working as a board member of this new state. And because it's independent. I mean, one of the things to really achieve equity and not recreate the system, you need something that can stand a step, work with state government, it seems to me, but stand apart as well. So, I would, whether it's local, i.e. regional, and through our COVID-19 committee, which you're on, and we working with United Way, or whether it's the state through 4CT, or whether it's both simultaneously, it does seem to me that this is something philanthropy should jump on in our region and in our state. Does that make sense to you?
It does, and Will, thank you for all your comments, and I'm thrilled to hear that it resonated with you and with others. I do think it does make sense for the structure that you outlined, and so I'm very happy to think about next steps there.
Yeah, because I think if we, the state is bleeding red on this, and the healthcare system, as you said, is bleeding red on this. This is something where philanthropy can step in very productively. We've already elevated racial and ethnic disparities to the top of our list in terms of COVID-19 response. So this seems to me to be a very tangible, very important step that we can take to advance that as we go forward.
Thank you, Will.
So there's a comment here that says, in light of today's conversation, the question of how the foundation uses race and ethnicity in its grant-making decisions needs to be asked. And I can address that a little bit. I would say that we do collect race and ethnicity data from our grantees and about the populations they serve. And we can share that data more publicly. And also we have the concept of equity and inclusion is at the center of our new strategic plan. So we are looking more deliberately and more closely at those issues and how they play into not just our grant making decisions, but all of the decisions we make at the foundation. Another question is, do you know of any efforts being made to reach out to seniors at New Haven senior centers like Bella Vista and Casa Otonel? Some of these seniors are homebound and many may not be able to get to a testing site. So I think this is specifically a testing question. I know Fairhaven Community Health Center was working with the folks at Bella Vista. And maybe the folks at Casa Hotel too. I don't know. Do you know the answer to that?
I'm not as sure, but likely. And I do want to say that, so that is true. I mean, we have to ramp up testing and testing access. And the reality is many people who need testing are not going to be able to travel for testing, right? To travel to whether it's walk up or drive up facilities. And so that's, in part why I lifted up what is really the first in space, right, for us here in the state, where Fairhaven partnered with Mary Wade to make sure everybody was able to get tested. And I will just say that this is, top priority at the state level too. We've been very grateful to have the National Guard come in and help us in our nursing homes where things are at crisis level. But this is I'm really pleased to say, like, this is an issue that is very much on everyone's radar, and the highest priority group to be first in line for testing as we ramp up, which is now.
There's another question here about testing. Is it true that the current tests for the virus have a 30% false negative rate? And if that is true, won't it make it difficult in terms of follow-up?
Yeah, so, I really appreciate that. This is something we think a lot about as clinicians. It's hard to find a test that's 100% accurate. And, we are dealing now with at least the most common test. We do know that there's a risk for some false negatives. So that is true. What all of and I will just have a sideline that, testing strategies continue to evolve, and we are hopeful that there are both more accurate, precise tests on the horizon. Also, that there are mechanisms for sample collection that will require sort of less of the personal protective equipment, that will be less invasive. So, saliva testing is on the horizon. We hope sort of intranasal testing, which is different than the nasopharyngeal, which has to go farther back. So we're hoping that the way we do the test will improve, as well as the accuracy. So it is true that there will be some false negatives. And, this is why, as we think about testing, the question has to come up in terms of, well, how frequently, if we're thinking about some of the more high-risk places like nursing homes, how frequently do tests need to happen then? And it probably isn't just once.
Marcella, are you able to talk about the efforts to advise and monitor businesses that may be opening, at least partially, in the near future, if they provide incentives for people to come back to unsafe work environment? What about the unemployed minority workers, especially undocumented? There's concern that these people will be putting themselves and others at risk by returning to work too soon.
Yes. So, in terms of, so I agree, right, that we have to be that this is a vulnerable transition, right? Whatever the reopen, which is in phases. And I would say one of the things that, I've heard a lot about recently is people's some frustrations and challenges as people try to access workers' compensation. And so, thinking about kind of some of these in policy bites, I suppose. So whether, so that is one area where I think, that we have to pay more attention to is for people who are sick, how do we not incentivize going to work? And then making sure that there are channels for people who are going to work and where things might be sort of unsafe for them to be able to report that with follow through. So those are two of the initial steps, I think, to tackle that. I will say that, I think it's a really important question that isn't, that's a little bit out of, purview for me, as far as I don't know all that's happening for the conversations with businesses as the economy attempts to reopen. But I do know for workers that we should make sure that there is some economic consideration so that the incentives at least align with adhering to isolating and quarantine if that's what's recommended.
Thank you. I have two more questions for you, and then we will wrap it up. What do you see on the other side of this as a clinician? How do you think this is going to change our healthcare system once we are beyond COVID-19? Maybe it's too soon for you to answer that, but I wonder if in your work you're already anticipating how healthcare might change, how we all access healthcare, how healthcare is delivered.
Yeah, again, another really great observation and point. So I think it's probably, I mean, it's probably soon to answer it in full, but it's definitely not too soon to ask it. And many people are. I mean, I think even if we look at that example of telehealth, I don't think that's something that will go away, right? I mean, we spend so much time, you know, thinking about access issues. And for those of us in the health equity world in particular, you know, challenges around transportation and our patients being unable to sort of make and keep appointments because of transportation challenges or because of childcare, or kind of other things that were predicated on physically showing up in the office. You know, I don't see us returning to a world without a really robust telehealth platforms. You know, I think about our patients living with disability. I mean, there's so many groups for whom having telehealth options, I hope, continue to remain, you know, available. So I think that's really one, you know, one example. I think we're going to have a lot of other organizational examples, just how we think about workforce, how we think about issues of kind of workforce deployment. I think that's going to be critical. There's probably going to be a lot around financing and how we think about financing in healthcare as well. So it's definitely, you know, keep your eyes on that space because I don't think the practice will fully return to how it was. But I think there have been a lot of great innovation. So I think it's going to be for the better.
Thank you. And some people are asking about your slides. We will have the recording of the webinar will be available on the Foundation's YouTube channel, and you'll get a link to that as follow-up to this webinar. And we'll try to maybe address some of these other questions in our follow-up too. But I have one final question for you, Marcella. I know for us at the Foundation, and at least speaking for myself, it's been so overwhelming to hear about the needs and demands and what is happening in the community as it relates to COVID-19 and the disparate impact. And what gives me hope is seeing how the community has really rallied around this, seeing what happened in the Great Give, seeing the generosity of the community and many of the people on this call. So my final question for you is, what gives you hope?
Oh, so much. I am so inspired. And that's why I really do think that we end on an optimistic note, because the outpouring of generosity, of time and resource and goodwill and social connection. And I am, you know, I feel incredibly privileged to sort of be witness to so many small and large moments and acts of generosity and kindness and outpouring. And for that, I am incredibly and deeply grateful, starting with the people who are on this call today for all that you're doing. So many given of their time as volunteers, extending in a difficult economic time, but to be generous with gifts. And it's making the difference. It's making the difference with each individual patient, in communities, in families, across the board. And so, you know, I share that, Christina. I'm very hopeful.
Thank you, Marcella. And thank you again for giving us your time today. As Will said, we don't know how you find the time for all of this, but we are all grateful for the work that you're doing. And thank you all for joining us today. Thank you.
So just, I want to add my deep gratitude, Marcella, for sharing all this information with us today. And thank you all for joining us. There will be an evaluation at the end, so if you have a few minutes, please take the time to complete it. And then we are planning another donor briefing in 2 weeks. You will also have a summary of this session. I know that there may be some questions that weren't answered, so please reach out to us. and you'll be hearing more from us soon. So have a lovely weekend. Thank you.